So if not, without further ado, we should proceed for the second talk, which is by our guest speaker. So Bancha, right? Bancha, I always don't know how to pronounce your surname, right? But so that's why I always call you Bancha, right?
So we are friends for more than 10 years. You cannot pronounce my surname, Patrick.
Yeah. Okay. So, wow, it's your time, Bancha. Thank you.
Thank you, Patrick. So my surname is Chernchujit. Yeah, it's not easy, right? So thank you, Patrick, and also the team. Thank you, Smith Nephew, for the invitations. Today I'm talking about the tip and tricks for fixation of the bony Bankart. Thank you, my 5 fellows, for preparing the document. So Priscilla, she's surprised, oh, you have so many fellows. So they work very hard to edit the video and also find the update informations about the bony Bankart repair. Okay, this is the outline of my presentation. Today I'm discussing about the diagnosis, surgical preparation, technical description, case example, okay, and new emerging idea. So the bony Bankart, actually, from the literatures, we found that the bony Bankart actually is more common than soft tissue Bankart. If you look at the pie chart, the bony Bankart is nearly 70% comparing to 30% of soft tissue Bankart. But most of the cases is small lesion, less than 13%. So that's why sometimes we neglect. We didn't see this small piece of bone. Only 17% have a large lesion. Okay. And not confused. Sometimes we confusing about the bony Bankart and the bone loss. Okay. So the bony Bankart is quite important. If you didn't recognize it, it can be resorption over time. So for the bony Bankart, we need to address and do the surgery earlier comparing to the soft tissue Bankart. Okay. So this is the study from Hirosugaya, our good friends. He found that in bony Bankart lesions, if you try to repair this bony Bankart, the size of the lesion, the size of the bone is getting bigger over time. You can see from the CT scan. Okay, this is the before surgery and after surgery. You can see that the size of the bone is getting bigger, okay, after the surgery. And examinations, it will be a bit different from the soft tissue Bankart because you can see the mid-range instability because it's the Bushnell bony Bankart apprehension test. It will be positive at 45 degrees. Okay, so in case you found that the patient have mid-range instability, thinking about the bony Bankart. Okay. So the imaging that we need to know is the X-ray AP, the graduate view, the true AP view. And also I like this view. The B view is the apical oblique or GAT view. This view you can see the heel sac, right? At the same time you can see the bony Bankart. It's very easy. You point the beam caudal 45 degree. Okay, we call this apical oblique or GAT view. Okay. Another view is the west point. West point is like axillary view, right? But you need to beam 25 degree. Okay. In practical, sometimes it's not easy for this west point view. Okay. And Hirosugaya also proposed a view called modified Bernacule view. Okay, for the bony Bankart lesion, you can see the difference between A and B, right? If you have some bone loss. Okay. But technically, I'm not sure it's easy. Okay, I myself never use this modified Bernacule. I like the GAT view. Okay, for my practice. So for the CT scan pre-op, you need to identify this bone. Always ask the technician to remove the head or the on-face view of the glenoid. Okay, always remove the head. Yeah, you can see better the bony Bankart lesions. So if the size is small, less than 12%, you can do like soft tissue Bankart repair. But if it's bigger than that, we should do the bony tissue Bankart repair. Okay. So this is the Hirosugaya he proposed the technique of the Bony Bankart repair. Yeah, he pointed out that we need to mobilize the tissue complex and repair the inferior labrum adjacent to the osseous fragment, and try to make a big bite and cover the fragment. He used the same like soft tissue Bankart, not so fancy, but make sure that you have a big bite, you get around the fragment. Okay. So this is my technique. I think the patient positioning is important because we need space. I didn't use beach chair position for the instability. This is what we propose in arthroscopic technique. We call the TU supine position. We do the simple traction using the skin traction. Okay, stabilize the head. We call this the TU supine position. The weight is about 3 to 6 kilo. Okay. So this position is quite easy because you also can do open surgery, and also you have less gravity effect. Okay, comparing to the beach chair or lateral decubitus position. Okay. So the leg plate is detached, right? Like this, and you have enough room to work. Okay. So in some situations, we have the problem if the patient have AC joint or rotator cuff, I prefer to do beach chair position. For instability, I need to do this traction position. So if you need to do both, I prefer this position we call the TU flexic position. You put the patient on the beach chair, right? And also attach the traction. So if you do instability, you put the head down, okay? And you can do instability repair. If you want to do the rotator cuff, okay, or you need to do surgery, you can do this beach chair position, okay? It's quite useful. We need some special instrument for the Bony Bankart. We need this metal, shuttle, because the problem is that when you're doing the Bony Bankart, sometimes the bone stuck inside the tip of your instrument, so you cannot pass the shuttle. So I always have the 4 portals for the instability. Okay, we have posterolateral portal. My posterior portal is not like routine shoulder posterior portal. We move it a bit lateral. We call this Kim's portal. And we have anterosuperior, anteroinferior, and 5 Ocock portal. So we have totally 4 portals, right? You see my posterior portal is very lateral, okay? So this portal you also can see very well, and also you can work very well. In case you have the Remplissage, you can use this portal for the surgery. And you have less gravity problem because if you put your cannula very posterior, you may have some fogging. This portal is just parallel to the floor, right? And then we doing 3 portal in the front. One just underneath the AC joint, one lateral to the coracoid. Another one is just above the axillary fold, right? So when we get into joint, there's always like this. There's a breathing. I start with my mid portal first. This is just above the subscapularis. This is anteroinferior portal, followed by the portal just above the underneath the AC joint, and then followed by the 5 Ocock portals. So this 5 Ocock portal is quite useful for the Bony Bankart because it's very low. You can pass your spectrum or the instrument very easy. Okay. So I show you the first patients. This is the patient with severe bone loss. Okay, Bony Bankart, acute. So after performing, first thing is to detach. Okay, so you see that this one has a very comminuted fragment on the anterior part, and this fragment also rotate 90 degrees. Okay, like that. So we need to flip this fragment. I always start my suture from the back, right? Because it's easier. You shift the inferior capsule up. Okay, and then I use my 5 Ocock portal pattern suture. like that and wrap around the fragment. I prefer using double load anchor. Okay, I like the suture fix. This is a suture fix from Smith Nephews. It's a double load. Okay, and repair the labrum just next to the bone. Okay, make a big bite, wrap around. Okay, like that. So this 5 o'clock portal is very useful to pass the suture around the fragment. Okay, I always use about 3 triple load anchors. I didn't tie the suture first because if you tie the suture, you cannot approach to the glenoid neck. So after I pass all the suture to the fragment, I tied one by one. Okay, like that. That's the first, second, and the third one. Okay, and try to reduce this fragment. I did not use the double pulley technique. Okay, because I think uh, it's a bit fancy and it's too complicated. So I think using this technique is very reliable and the result is pretty good. Okay. So I follow Sugaya techniques. Yeah. So the second one, this is the patients with big bony Bankart lesions. And also here's Hill-Sachs lesions. From examination, the shoulder is pretty loose. So first, so in the bony Bankart lesions, I think you need to address earlier. Try to fix the bone as soon as possible. Okay, don't wait too long because if the bone heal to the neck, there will be some difficulties to remove it. So first, you need to mobilize this bone. Okay, going down until you feel like this fragment of bone is free. Okay, okay. So sometimes you take 10 to 15 minutes for this mobilization. Okay, don't start to repair if you cannot mobilize the tissue. Okay, after you mobilize the tissues, then you're doing the same way. Okay, I use double load suture fix. Okay, to don't worry. Sometimes your bone is like tilting. I mean, you are doing very tight, right? When you tie the suture. Don't worry because the head, when you release the traction, is to mold this fragment to make it flat. Okay. So this is the third one. Tie the fragment. So most of the time I have 3 double load anchors. Okay, see that after the repair, it's look very stable. Okay, this is the. If you look at this, it's a bit over reduction, right? You look like over reduction, but don't worry. After the head, you release the traction, the head will mold this fragment to make it flat. Okay, I show you the next patient. This patient has the bony Bankart, also have the tuberosity fracture. See that? Very big piece of bone, right? But luckily the tuberosity was here. Okay, so I don't need to do the tuberosity fixations. Okay, we have 3 portals. So first you need to detach this fragment, really big piece, right? I think this is the very important step. You need to mobilize until you see the glenoid neck. Otherwise, you cannot pass your suture around the fragment. I always start from the back. Okay, and then using this is 5 o'clock portal. For the 5 o'clock, I just use the half pipe using dilator. And your anchor should be above, above your, you see that is the suture hook, right? Attach the second suture fix. Okay, and after you pass out the suture, you can do knot tying one by one. You can see that I have 3 portals in the front, right? Anterosuperior, anteroinferior, and also 5 o'clock portals. Okay, secure fixation, a little bit over reductions, but don't worry, over time this bone heal nicely. Okay, and the patient is quite happy. This is the 1 year after surgery. The patient have good motion, full range of motions, and also no signs of instability. Okay. So sometimes you need to do Remplissage also. In case you have bony Bankart with Remplissage, I will start doing Remplissage first. For Remplissage, I use the helicoil. Like you're doing the rotator cuff, I put the helicoil in first. Okay. Okay. This is the helicoil. I prefer using triple load helicoils because okay, you can pass 6 sutures into the posterior capsules, right? So I use the suture hook to pass and fix this Remplissage. So after the Remplissage, I will not tie the knot. Okay, do like that. Okay. So if you do Remplissage later, sometimes it's not easy because your joint is already stabilized. Right. Before you're doing the bony Bankart repair, the joint is loose. It's easier for you to do this Remplissage. Okay. So for the triple load, I pat the suture 1, 2, 2, 1. Okay. Okay. You see that there's a big bony Bankart in the front, but I didn't touch that. I fixed my, see, this is after you finish your Remplissage, it will cross the space, okay, fill the gap. So there's some literatures mentioned about the suture bridge, yeah, for the bony Bankart. So I myself think it's a bit complicated because you need to have 2 anchors, and sometimes our Asian people have very small glenoid. So sometimes it's too much to put the 2 anchors at the glenoid. Okay. So first you put the anchors at the glenoid neck and pat the suture into the around the fragment. Okay, like that. The same like we do. Okay, and after you pass it, you are doing like double roll. Okay, like you do rotator cuff double roll repair. Put this in. So this is another way to do the bony Bankart repair. Okay, I did that for the very big size patients. Okay, but for the small size patient, I prefer doing the technique I show you. Okay, so this is the bony Bankart repair using suture bridge technique. But this technique, when you repair it will not over reduction because you reduce and push it down. Okay, I myself don't like this because I think you make it over reduction is good because after you release the traction, the head will mold your fragment to make it flat. Okay, so we have the meeting, APCAS TOSA meeting in the end of September. Thank you, Patrick, for your coming and support Thailand. Okay, so we would like to invite Hong Kong people, Chinese people to Thailand, but I know it's not easy to travel to Thailand at this moment. But anyway, okay, if you come, we are really happy. Thank you very much. Thank you, Patrick.
a very nice presentation and very skillful demonstrations of your technique, right? First of all, still a lot of Hong Kong people will come over to Pattaya, so we'll see you, right?
Oh,
Don't worry.
wow.
Okay.
Thank you, Patrick. Good news.
Yeah. So maybe first of all, maybe we would like to see if our colleagues have any questions, right? Any questions? Benjamin, maybe I start first, right?
Yeah.
Well, what's the limit that you choose in terms of the size of the bony fragment that you use your own way rather than the suture bridge, or you may like to, essentially make a mini open or percutaneous screw fixation. So is there any size limitation for using this, your conventional technique of fixing this bony bank?
Patrick, yeah, that is a very good question. So it depends on the size of the fragment. If the size is like wedge shape, okay, and you think that you can repair this back, and the size of the fragment is much smaller than the screw. When you put the screw in, you need to make sure that the screw is bigger than the size. Okay.
Yeah.
So if the size is big, okay, and you think that the screw is okay, comparing to the size, you can put the screw in. But I think that is the should be like really big shape, really big. But most of the cases we can manage like doing the suture fixation. So look at the size of the fragment and also the screw. Okay.
Yeah, very good. Well, the other question, yeah, please, Sammy, our colleague has another question.
Hello. Because if you put the screw in and the size is small, you can break that fragment.
Okay. Yeah, that's the trouble, right?
Yeah, that's the trouble.
Excuse me. I'm Sammy Mac. In my locality, in my unit, many of the time the Bony Bankart unfortunately is delayed presentation.
Yes.
So may I ask your time limit that you will still try to mobilize it, or you will give up? Will do a reconstruction.
Okay, very good questions. That's the study from Sugaya from Japan. So even this fragment is very long, very chronic. Don't give up. You get in and you detach this fragment using the chisel, okay, or Bankart knife to break it, okay, and then reduce it back. Even this is chronic, we have no time limit because this fragment, even it's small, it can get bigger over time, right? Like I show you Sugaya publication in JBHS. Okay. Same problem. Some patient come very late. Okay. But if the patient come earlier, it's good because this fragment will not resolve. If you let this fragment over time, it will get smaller. Okay. But try your best to reduce this fragment back. Okay. Make a big bite, get around the fragment.
Good. So any other questions?
How about your idea, Patrick, about the chronic case?
I think let's get a try and see.
Right.
Fix it. Very often, I think. Well, I have encountered cases really difficult.
Yeah.
And very fragmented. But at least you may not be able to repair like the whole fragment.
Yeah.
You debride with this a lot. The size of the fragment may be reduced, but at least you have the fragment, the bony fragment with the labrum intact. You fix it back. That will probably be good enough, right?
Yeah.
That's
because I saw many surgeons, they skip to do the Latache or bone work right away. So I give the patient another chance. Okay, if there's some fragment attached to the neck of the glenoid. Okay, and most of them very happy.
Good. William, yeah.
Because if this time is failed, we can do another time for the Latache.
Exactly.
Yes.
Dr. William Chan, thank you very much for your nice talk. I would like to ask if there is any surgical tips or tricks that you can show us, because I know you use a lot of the spectrum hook to pass through the bony fragment or underneath the fragment, because this is the most difficult part in bony Bankart surgery.
Right.
How do you achieve it? If it is not, we don't have the suture spectrum like your that is so sharp, you can pass through the bone. The way and tips you can enlighten us, because many of us, we are just using ordinary suture hook or spectrum.
Yeah. I think the tip is that if you use because the anteroinferior portal is just above the subscap, right? So if the piece of bone is big, you cannot hook around because you're coming from the top. You're coming from the top and you need to repair the fragment that is lower. So it's impossible using the spectrum or the acoupas to pass through this. So that's why you need another portal very low, like 5 o'clock portals. And you can pass it like straight, okay? Go underneath, okay? And try not to hook around and make this needle up to the level because it's impossible, okay? So the needle should go through to the neck, going down to the neck, okay? Because it's impossible to hook around. And then you go down to the neck to retrieve this shuttle, okay? Like I show you. It's impossible. If you try to hook around, that means this fragment is not big enough, okay, that you can hook around. But most of the time you cannot because big fragment, okay? So use the lower portal.
It's like the biomechanics of the force, right?
Right.
You
Right,
need to
Patrick.
get the good puncture, right? Straight away. I think these are very good tips, right?
Yeah. Go
And
down.
also you use the metal wire as a shuttle rather than
metal wire because
that
sometime-
can take away the blocking the
the
the tip.
Yeah, it's blocking the tip. That's right, Patrick. So metal wire is easier, right?
Good.
Go to the neck. And very important, you need to mobilize. Don't be scared to mobilize. It's quite safe because you follow the glenoid neck like we do shoulder arthroplasty. If you mobilize the tissue around the neck, it's quite safe. You will not injure your axillary nerve, okay? Before starting to repair, you need to mobilize, make sure that this fragment is floating, easily mobilized, okay? And don't need to do the fancy way. Okay, I saw many literatures, they try to make double row to anchors, but for our Asian size, sometimes it's not easy. And these two anchors may be jamming, right? So I think I follow Sugaya technique. Yeah.
Lovely. Okay.
May I clarify with you that you said you always use the posterior portal to tackle the IGHL first or the post-anterior inferior labrum first?
Right.
And you think you can get more bite with this, or is it easier before you mobilize the fragment, or is there other technique? Any tips on this?
Yeah, because most of the time the rebel repair is tear neck down to the 6 o'clock. So using the anterior portal is not easy. So I always use my posterior posterolateral Kim's portal to wrap the axillary pouch. That is my first stage. Okay, and shift it up. Yeah, you can mobilize because this patient will have tear extend to 6 o'clock. You need to do the inferior capsular shift also. You need to shift everything upward. Okay, so that's why I start from posterior. And my anchor will be above my suture, okay, always, because you want to shift upward, okay?
Thank you very much.
Thank you, Bancha. Right.
Thank you.
So I think it's a very, very good, Bancha.
Thank
You are
you.
always our good friends of Hong Kong, okay?
Yeah. Thank you for sharing your experience.
Thanks for your time. So
Patrick, can I have one more?
Oh,
question?
sure. One more last questions, right?
Yeah.
We'll talk also because what do you think about using the Regenitech, especially when it's first come to the market, is for some partial tear, or is there any experience?
Have you used that, Bancha, the Regenitech?
Not yet in Thailand. I just heard that.
Patrick,
So Smith nephew just introduced this to me last month. Yeah.
Okay.
So very interesting.
We'll see.
No
I think well, I don't think it's we should not take it as more as those previous marketed biological enhancement or like graft patch or graft jacket. This is completely different. It's more on biological. This is you can't take it as like a strength enhancement. But on the other hand, I think at least we try on this cohort of cases. Later on, if we really have some relatively fair or poor quality tissues, after repair, we may still have some hope on that. Right?
Yeah.
It's the whole purpose.
Yeah, I agree. It's quite interesting. May I add some like bone marrow aspirate concentrate, the BMAC, to inject of this scaffold to heal nicely? I'm not sure. Patrick, what do you think?
I'm not sure, right? Very much like people use PRP and so on, right? The evidence is not very strong, but I think now the trend, as I mentioned, is people like you have very good surgical technique and so on, but somehow we may not be able to overcome the biological side, right? So that's why we explore these options, right?
Yeah.
Thank you very much, Bancha, right?
Thank you.
I would say that Bancha is the one I most admire. I think is he is not just a good surgeon, it's very practical, very down to earth, know all the little tricks. Yeah, if I have shoulder and knee problem, I would definitely fly to Bangkok to ask him to. He is a guy who operates on a lot of surgeons, including China. Okay, thank you very much, Bancha. We have to take a group photo.
Yeah. Of
You
course.
stay on the screen, okay?
Yeah. Group photos. Sorry, I cannot join you on site.
Yeah, just
so
wait for a while.
my fellows also join.
Yeah, we'll meet you in Bangkok and Pattaya.
Yeah, I have Indonesian fellows, Adrian. I have Malaysian fellow, Dr. Ling.
Hi, Adrian. Good to see you. And Theo. Okay, thanks for all your fellows here. Right?
From India. Dr.
Nice,
Ling.
nice.
Yeah.
Okay,
well, take good photos.
Let's say 1, 2, 3, and then look at the camera. Okay.
Okay.
1, 2, 3.
Very nice.
Very nice.
Can you do this way? Patrick?
Okay, do it again. Right, thumbs up.
1, 2, 3. Okay.
Someone is driving, huh, Adrian? Okay. Oh, you're on the other side. Okay. Nice to meet you, Bancha. We'll see you next month in Bangkok.
Okay, of course. We are waiting for you.
Thanks for the fellows. Thanks. See you later.
Okay.
Bye-bye.
Bring a lot of Hong Kong surgeons to Thailand.
Yeah. We'll do. Okay. My promise. Okay.
Okay.
See you. Bye-bye.
Bye.